Welcome to the webinar, Using New Oxygen Conserving Technologies to Reduce Costs, Enhance Patient Outcomes, and Grow Revenues. Now I'd like to introduce our speaker, Mitch Yoel, MPT. He's our Executive Vice President of Business Development and Government Affairs at Drive Medical. Prior to joining Drive, he worked for 11 years as an HME provider and for 4 years as a clinician. During that time, Mitch worked for an NIH-funded grant doing pulmonary rehab at the National Emphysema Treatment Trial. Now I turn the presentation over to Mitch.
Thank you, David. I just wanted to start off by going over what to expect from this presentation. So there's a few goals or a few topics that we're going to cover. First, what is the value proposition for using oxygen conserving devices as a portable modality? Then I want to go over what the different types of conservers that exist in the market today are and where those market technologies are headed. Third, let's talk about what patient populations are best served by which types of conserving devices, matching the products to patients, if you will. And fourth, what delivery algorithms exist, because it's probably the number one most critical factor in saturating patients, is are you matching dose to patient activity level and therefore need or not? And then finally, how can we use all this information to grow sales? What is the revenue opportunity from all this information? So first topic, the value proposition. I'm sure not much time needs to be spent talking about the reimbursement and audit environment that exists today, but it, needless to say, does dictate efficient management of patients requiring portable oxygen. With a fixed reimbursement per month from Medicare, modality neutral reimbursement, very few providers are excited about making multiple trips to a patient's home each month that are not reimbursed to deliver, full tanks and pick up empty ones. So a conserving device decreases the operational costs associated with that, and that is its value proposition. If it costs you $15, $50, $80 to make a trip to a patient's home based on your business model, doing it 1, 2, or even 3 times fewer per month than you otherwise would with a traditional continuous flow regulator is a pretty powerful value proposition. And certainly these devices pay for themselves in a very short period of time. There are not a lot of providers out there that are putting regulators out as their standard of care for portable oxygen patients. Most providers have bought into this value proposition. Of course, for any portable oxygen modality, there are multiple considerations, and these are not all inclusive, but some of the more important ones are can't get away from it, initial acquisition cost. Do you want to spend $1,500 or $2,000 on a POC? Do you want to spend $150 on a conserver? Do you want to spend $15 on a regulator? Liquid oxygen, initial acquisition costs, but despite financing, are a factor that needs to be considered. Financing can certainly mitigate those costs. Operational costs, different modalities are going to require different number of visits to a patient's home per month. In the vast majorities of payers, they're not reimbursing for those trips to the patient's homes, so the fewer costs per month in general, the more profitable you will be. Total cost of ownership, things like warranties, reliabilities, service calls, all those things play into what the total cost of any modality is. And then there's the reason that, our industry exists. Satisfying a patient, both in terms of their quality of life and in terms of their clinical outcomes, is critical to the success of a DME provider. Without taking the patient into some type of consideration, probably you get fewer and fewer referrals and more complaints, and ultimately less and less revenue and less profit. So patient satisfaction and clinical outcomes are an important consideration. And then how can we use the various portable modalities to actually grow revenues? Different technologies impress different referral sources different amounts. So are conserving devices a modality that is of interest to referral sources? And what I would say is that conservers are a proven, effective, and efficient portable modality option that can address all of those considerations in a very cost-effective way. So moving on, there's a theme in a lot of DME, and that theme is matching the right technology to the right patient. Most products within the DME category have a niche in the market. It's a matter of what are the objective strengths and weaknesses of each individual product, and how can you match that to the individual needs of a patient. So in this case, by matching the right conserving device technology to the right type of patient, everyone can win. The patient can get better clinical outcomes, feel better, be more satisfied. The clinician can get fewer complaints from their patients and be happier with the providers that are servicing those patients. The payors can incur fewer costs associated with the negative sequelae of desaturated patients that have prolonged desaturations get comorbidities, they get more hospitalizations, and there's more cost associated with them. And of course, the provider gets efficiencies in terms of matching conserving device technologies to the right type of patient. The provider will make fewer trips to the patient homes and have more satisfied patients with fewer service calls. So that is the value there. So let's get into what exists in the market today and where the market is headed. There are four main categories, if you will, of oxygen conserving devices. I would classify them as a reservoir conserver, a pneumatic conserver, an electronic conserver, and an auto-adjusting conserver, which is really a subcategory of electronic. So let's talk about reservoir oxygen conservers. Reservoir oxygen conservers are the original conserving device. Invented in 1983 by Chad Therapeutics, they reduced the liter flow required to achieve adequate saturations. So this is really a high-flow, comfortable alternative to a mask that allows patients to eat, drink, and speak unobstructed. If you have a high liter flow patient requirement, here is a device that can allow you to set your continuous flow modality to a lower liter flow setting and achieve equivalency with the original liter flow requirement. This product has the lowest initial acquisition cost of any conserving device available. It is disposable. These are made to last about 3 weeks. They're usually bought as a case of 24. And they're very simple to use. They're essentially a nasal cannula substitute. You can see here on this slide that there are two types. One has a reservoir directly under the nose called the mustache style reservoir. This is an oxidizer, it's called. The other reservoir is a pendant style reservoir, and it can be hidden under the shirt of the patient, so it's unobtrusive. Also called an oxidizer. And because all you do is wear these products and they intuitively work, there is really very minimal, if any, instruction needed to the patient. What's not so intuitive is exactly how these products work. So let's talk about that for 1 minute. In both models, the reservoir function is similar. They're just in different places, one under the nose and one under the shirt. What happens is, upon exhalation, that reservoir is thrust forward, and it creates a chamber. And that chamber stores oxygen that is coming from a continuous flow device. As you inhale, the membrane is drawn back towards the patient, and it delivers a bolus of highly pure oxygen, and that is in addition to the continuous flow. So essentially, or effectively, what you get is a higher FiO2 than you would otherwise get with the same liter flow. And if you look at this chart below, you can see some equivalencies. And there have been tons of clinical studies done on this product. And in fact, 50% of the sales of this product are to acute care institutions. Hospitals use this. But on this chart, if we just took two quick examples, the most common supplemental oxygen setting of 2 liters per minute, instead of using 2 liters per minute, you could set a device when used in combination with an oxidizer to 0.5 liters per minute. Obviously making that device last longer if you're talking about a compressed gas cylinder, a liquid reservoir, any type of continuous flow oxygen. Likewise, if you look at a higher liter flow setting, let's just take 6.5 liters per minute as an example. With the oxidizer, you could set that continuous flow device to only 4 liters per minute and achieve the same liter flow equivalency. Now, in practical terms, that's phenomenal, because now, since 6.5 liters would normally require, if you're using a concentrator, a 10-liter concentrator, you can now get away, if you will, with using a 5-liter concentrator and give the patient the same equivalency of oxygen. So just to review and talk a little bit about when to use this particular type of conserver, this is ideal for high liter flow patients, for the reasons I just discussed. Especially high liter flow patients that have difficulty tolerating masks like non-rebreather masks that can make people feel claustrophobic, prevents them from easily speaking, eating, drinking, things like that. Also, if you're using a higher liter flow with a nasal cannula, we all know that whether you're using it with a humidifier or without, patients can get nasal irritation associated with those higher flow rates, and this is obviously going to mitigate that. Might be perfect for hospice patients who are often on higher liter flows, and we're talking about end-of-life comfort care, so it would be very appropriate for them. It's used very commonly with liquid patients. Rather than doing a liquid reservoir fill or swap out every 2 weeks, you might be able to do that with less frequency if you're using an oxidizer. We already talked about the 10-liter concentrator value. And in general, you can access up to a 4-to-1 savings ratio as compared to continuous flow of oxygen with the reservoir conservers. So moving on to the most popular type of conserving device, the pneumatic oxygen conservers. Now we're talking about devices that offer very high savings ratios, up to 6-to-1, meaning an M6 cylinder that might last on the order of 45 or 50 minutes at a setting of 2 on continuous flow could now potentially last approximately 6 hours just by using a conserving device. So when you talk about the finances of things, and you talk about doing fewer deliveries, and you talk about making patients more free, more liberated, and able to function in their community, having 6 hours on a tank that you would otherwise have 45 minutes on is an obvious and compelling story, I think. Other nice things about pneumatic oxygen conservers are that they are small and lightweight. What do end users primarily care about when dealing with compressed gas? How small a tank can I get? How lightweight can I get it? And how long can I make it last? Pneumatic oxygen conservers are great for all of those criteria. And what many providers also like is that they do not run on battery. So you're not getting service calls for someone who is incredibly capable of swapping out the 2 AA batteries on their TV remote control, but for whatever reason is not capable of swapping out the same 2 AA batteries from their oxygen conserving devices. So a lot of DME providers say, I like to use conservers that do not require batteries, and that's where pneumatics fit in. Instead, these are powered by the compressed oxygen, the compressed gas that's in the cylinder, and there are diaphragms, sensing diaphragms, and delivery diaphragms that open and close when the negative pressure of inhalation begins. Also, very minimal instruction required. This is going to go on a tank the same way a traditional regulator would go on a tank. It's going to tell you how much oxygen is in that tank with the same gauge that a regulator would. There's a flow selector. That just you turn a dial and you tell it the number of liters per minute equivalency that you'd like to use. So pretty minimal instruction required. Now, when I use this product, Most providers that I talk to use this a pneumatic conserver as their go-to conserver. This is their first line of defense, if you will, against continuous flow. And I view it as an excellent combination of when you think about cost of goods, patient satisfaction, total cost of ownership, and clinical efficacy. The pneumatic conserver is the most popular one with good reason. Now, in progressive pulmonary disorders, things like COPD, I would suggest this is used earlier on in the disease process. And the reason for that is, if there's one drawback to a pneumatic conserver, it's that it is not as sensitive as some other conservers might be, like electronics. And by sensitivity, I mean likelihood to trigger, or the negative pressure required upon inspiration to cause the device to trigger and supply a bolus or a fixed volume of oxygen. Since earlier on in the disease process, most patients have a higher max inspiratory pressure than they will later on in their process, I would recommend this is used earlier on. All right, let's move on to our third type of conserver, the electronic conserving devices. These used to be the standard of care. They actually existed after the reservoir, but before pneumatic conservers existed. And more recently, they were really replaced by smaller, lighter weight, cheaper or less expensive pneumatics that don't require batteries. So I just listed a whole bunch of reasons not to buy electronic oxygen conservers, but let's give the objective information about them, what's good and what's bad. Savings ratios are not as high as they are with pneumatics. They're slightly less. You can still get on most electronics a 5-to-1 or so savings ratio, which is still very good. And the trade-off there is you do get larger boluses. So you're giving more oxygen, which intuitively and certainly logically is the reason that you get slightly lower savings ratios. And this works differently than pneumatics, of course. There's a vacuum sensor. It tells the processor that's inside the electronic conserver when an inhalation begins. It opens up a valve for a specific period of time, and that length of time is dependent on the flow selection. So whether you've chosen an equivalency of 1, 3, 4, 6, that will determine the period of time that the valve is opened and oxygen is delivered for to deliver that bolus. So when would I use an electronic? We've already said that there are some disadvantages as compared to pneumatics, so let's talk about that. So the thing to know about electronics is that they are highly sensitive, much more sensitive than pneumatics. So someone who cannot breathe in as hard or with as much force or with as much negative pressure as someone else are more likely to trigger an electronic conserver than they are a pneumatic. So clinically, that makes a big deal, because you can talk all you want about how large the volume of oxygen is delivered per breath on varying conserving devices. If that conserver doesn't trigger on a breath, you're getting exactly 0 mLs of oxygen out of that tank. So sensitivity is a highly critical feature when it comes to conserving devices, and electronics excel there. Also, what's happened in recent years is the cost differential between an electronic and a pneumatic has really gotten much, much less. So you're talking about potentially a $10 difference. I would say an average pneumatic sells for approximately $130, and an average electronic sells for approximately $140. Obviously, different manufacturers have different pricing structures. There are, volume discounts. Different providers have different prices, but, overall, that's what I see in the market. So you're talking about a $10 difference for a product that is clearly going to make you feel more comfortable that it's going to trigger every breath. Battery life, probably the number one reason people did not use oxygen conservers that were electronic in the past, has vastly improved. They used to be on the order of 3 months. Now, thanks to technologies like auto-on and auto-off features and just more efficient processors, battery life has improved to 2 years on these products. So Big difference, to the point where it has effectively removed that objection from the field. If you can go for 2 years without worrying about a battery change, you're in pretty good shape. And the user interface is also much simpler than it was in the past. There used to be, satellite conservers and multiple connections between the satellite and the conserver and the tank and the patient, and everything had to be set. Now it's really quite simple. There's one button to press. It illuminates the liter flow equivalency that you've chosen, and everything else is automatic. Another nice thing about an electronic is some pneumatics are very quiet, which is a good thing. If a patient's in, a movie theater or a museum or, a religious sanctuary of some kind, anywhere where it's very quiet, having a quiet conserver is a benefit. For those of you who may not know, conservers that are louder might sound something like this each time a patient inhales. You might hear that in a movie theater once in a while. The nice thing about an electronic is that it gives you a visual cue with each breath. So the patient can feel more comfortable. If they can't hear the conserver triggering, they can feel more comfortable that they are getting oxygen with each breath because they can see a light illuminating on the dome plate. So, just the third bullet point here, I say use later on in progressive lung disease or for any patient that has difficulty triggering a pneumatic. Again, the idea here is to minimize cost, minimize operational cost specifically, minimize deliveries, and maximize patient saturation and satisfaction. So you want to avoid regulators or continuous flow regulators and try to use some type of conserving device if you can. So before we get to where the market is headed in terms of technology, I just wanted to take a minute to talk about, are conserving devices working? Well, I have 2 studies for you here on this slide and the next slide. They're simple studies. 33 patients on this slide were evaluated. They all underwent a 6-minute walk test. Their saturation was monitored. 57% of them could not maintain adequate oxygen saturation with their home setup as is. So if they were on an M6 cylinder with a conserving device set at an equivalency of 2 per the doctor's orders, 57% of those patients were satting below 88%. Out of those patients, 18% needed a change in liter flow setting. 39% required a brand new modality, a new unit. So that is not good, but it is consistent with what you hear from many clinicians. There's an impression out there that conserving devices or pulse dose devices do not work well. We're going to talk about why. This is just another study essentially saying the same thing. In this study, a third of patients desaturated during a 6-minute walk test. 67% of them saturated on their existing device after being moved to an auto-adjusting unit, and they were able to lower their base setting. We're going to talk about auto-adjusting in a minute. So why aren't we saturating patients? Well, first of all, a conserving device is not a conserving device is not a conserving device. There's differences between conservers. The sensitivity between conservers is different. The bolus size for each conserver is different. You go to, 3 different manufacturers, you're going to get 3 different bolus sizes, 3 different amounts of negative pressure required to trigger, and you'll get different delivery algorithms, which is, in my opinion, one of the most important factors in determining whether a patient is going to be saturated or not. So we're going to talk about that on the next slide. Other critical factors in determining whether a patient is going to be saturated is the speed and the timing of the delivery. Where in the inhalation-exhalation breathing cycle is that bolus being delivered? We know if it's not in the first 2/3 of inhalation that it's not useful. So it's critical to know where in the cycle it is being delivered and with what speed. And a big topic in the industry, and has been a big topic for the last decade, maybe more, has been that 2 liters per minute does not equal a setting of 2 on a conserving device. And a setting of 2 on one conserving device does not equal a setting of 2 on another conserving device. So there are equivalency issues that are compounded by the fact that very few clinicians are doing titrations on patients both at rest and during exercise, and it's becoming harder and harder for HME providers to do those titrations because of all the reimbursement issues that are going on, and manpower reductions and operational costs. And all of that is compounded by the fact that we have a lack of control over what patients do. In many cases, patients just decide to titrate themselves. They decide to turn up their leader flow setting when they feel they need to, and to turn it back down if they remember to when they feel they don't need higher leader flows anymore. And that often will result in both poor saturations and inefficient conservation. So, before we talk about the solution to all that, let's talk about just some of those delivery algorithms. It's worth, I think, 2 slides. So, different conservers deliver oxygen in different ways. One common way is with an algorithm called fixed minute or minute volume or fixed minute volume, however you want to phrase it. And this is a fixed volume of oxygen that is cut up into the number of breaths you take. So over the course of 1 minute, there is a set volume of oxygen. The faster you breathe, the less oxygen you will get per breath. The slower you breathe, the more oxygen you will get per breath. And that is depicted on the picture on this slide, where you see the equivalent of someone breathing slower on the left side with that stack of chips, and the chips are thicker. And it's the same height of chips on the right, but it takes more of them, so each chip is less deep. I don't know if that's the best analogy, but that's what I could come up with. So I think the important thing is the faster you breathe, the smaller the dose of oxygen you get per breath, which is certainly counterintuitive. Normally patients begin to breathe faster when they're active and when they need more oxygen. The only positive I can say about a fixed minute volume algorithm is that theoretically it will allow you to more precisely calculate how long a tank will last, because you know per minute exactly how much oxygen is going to be used. And I put in parentheses kind of sort of, because in the real world it's not precise. In the real world, what happens is when patients get short of breath and they're breathing faster and they're getting a smaller dose of oxygen and they're oxygen starved, they are going to turn up their liter flow equivalency no matter what you tell them. So if they're set at a setting of 3 and they're short of breath and they're feeling like they need more oxygen, they're going to turn up the dial to 5 or 6 or whatever it goes up to until they feel saturated and they feel good. So you can't really say how long a tank is going to last when you have this uncontrollable variable of a patient that is changing their setting. Maybe a better analogy than the chips that I put in there is the pizza pie. If you've only got one pizza pie and you have 3 people at the party, and then all of a sudden 10 more people show up, if you don't have the ability to get more pizza, the only thing you can do is cut smaller slices of pizza, just like you get smaller slices of oxygen as you breathe faster with fixed minute volume. Alright, so I beat that to death, so let's talk about the other common algorithm, which is uniform pulse. Uniform pulse volume is really the opposite. This clinically is a better algorithm. This is better matching oxygen dose to patient need, because as you take more breaths, you just get more oxygen. You're getting a uniform pulse of oxygen regardless of breath rate, usually up to a max respiratory rate of something like 35 or 40 breaths per minute. So intuitively, it makes sense. As the patient's breathing faster, they're getting more oxygen. It also makes sense on the conservation side. As they're breathing slower and they don't need as much, they're getting less oxygen. So it's a much more efficient algorithm. If there is a negative, I would say, of course, it's harder to calculate the tank durations precisely, because the tank duration is going to be dependent, as it should be clinically, on patient's respiratory rate. Here on the pizza pie or on the chips, as more people come to your party, you give the same size slices, you're just able to make more pizza. So that's the uniform pulse algorithm that are put into some conserving devices. So just as a pictorial example of how this works, the dark blue device, well, let me start with the X and Y axes. On the Y axis, you have the volume of oxygen delivered in milliliters at 2 liters per minute. And on the X axis, on the horizontal axis, you have breaths per minute from 20 going up to 38. In the navy blue, you have a bar graph of a device that uses fixed minute volume. And in the light, I don't know what that is, green, light, I don't know, off-white, you have a device using uniform pulse technology. You can see that the fixed minute volume device gives you a smaller bolus volume as breath rate increases across the graph. The uniform pulse gives you the same uniform pulse with each breath, even as breath rate increases, effectively giving you more oxygen. So, why else aren't we saturating patients? We all know the problems that exist with clinicians and the prescriptions that they write. Often patients are not titrated at all. If they are titrated, they are unfortunately very often titrated only to their requirements for oxygen at rest. And very often a 6-minute walk test or some type of activity-based testing is not done by the clinician. When that happens, the conserver is set too low, and the patient will saturate just fine at rest. It's just that as soon as they get up and start walking around and walk up and down a flight of stairs, they start to desaturate. And this is where referrals get frustrated, and this is where conservers can get a bad name. If you look at the graph, it just is showing you how at rest the device is probably set correctly, but then as you exercise, it's set too low for that exertion and the patient desaturates. The converse holds true when conservers are set too high. This is a clinician that probably has done a good job titrating a patient during activity, writing a prescription, though, that doesn't necessarily match the patient's need to oxygen dose. It's just using the limiting factor of the exercise need. So it's very often, as you can see in the graph, set too high. It's perfect for when the patient is exerting themselves, but as soon as they are resting, you're wasting oxygen. You're giving the patient more oxygen than they need. And we've found that patients rest far longer than they are active for. Resting is accountable for 70% of the time for an average COPD patient. So this is what's driving increased number of deliveries per month. This is what's driving operational costs. And this is as big a problem as the clinical problem of the oxygen conserver that's set too low. Because this is what is driving people to be less profitable and potentially out of business and unable to serve patients in the first place. So how do we correct this problem? Well, we know that we already talked about how patients will manually titrate their devices ineffectively and inefficiently. But a solution would be a device that auto-adjusts, a conserver that can toggle between a preset titrated resting setting and a preset activity oxygen setting, automating this for the patient. That would be an efficient way to maximize both saturation and conservation, and is really the key to this whole presentation, in my opinion. And the future is here. This is not where the market is going to be a year from now. These devices exist today. And you can see on this graph, patient is well saturated at rest. Patient is well saturated at exercise. You are not wasting oxygen while the patient is at rest because you are lowering the dose while the patient is at rest. Now you have fewer deliveries and you have pleased referral sources. So how do you match dose to activity level? There are two of these devices that exist in the market today. Both of them, as an aside, use uniform pulse technology. Neither use fixed minute. And these devices basically use either, one device uses a motion sensor and the other uses breath rate. And both of them use those metrics to determine when to increase the dose to a preset activity setting and when to decrease the dose to a preset resting setting. So one's using an accelerometer to detect motion and say, okay, this person is moving around. They're probably going to need more oxygen very soon. Before they get short of breath and before they desaturate, let's give them a higher dose. And then as soon as that patient sits down, the accelerometer in that device detects that and lowers the dose to the resting setting. And the same holds true for the device that does this based on breath rate. Obviously, patients need more oxygen when they are active and less when they are resting, and auto-adjusting conservers give exactly that, higher doses during activity and lower during rest. Here's an example of one of these products. I just wanted to show you how simple the user interface is for something like this. You can see that this is an electronic conserver. There is two icons. One depicting a person resting, one depicting a person that's active, and you simply depress the rest button, the rest icon, until the desired liter flow equivalency setting is illuminated, and then you do the same thing for the active setting. And of course the active setting has to be equal to or greater than the resting setting. You would never want the dose to go up while the patient is resting and then to go down while they're active. Just some features of a product like this. Here, instead of the 2-year battery life that you get with a traditional electronic, you still have a very good battery life, but it is 1 year instead of 2. The processor requires a little more energy. 6 liter flow settings. There is a continuous flow option, as there is on most conserving devices nowadays. It will sense a breath and deliver a bolus in the first half of the inspiratory cycle. Weighs under a pound, and it has the auto on, auto off feature. Now, when would I use this? If I were on the provider side again, this could be your first line of defense. There are providers out there today that want to market the fact that they're using the highest quality, most clinically efficacious devices out there to their referral sources, and who want to do right by patients, and they're putting this out there. For other providers, and I think this is just as valid, this might be the last line of defense, and that's okay also. These devices are obviously more expensive than electronics or pneumatics. So for some providers, it might make sense to use this, but only when necessary. And I would submit that even a $15 regulator will cost you far more over the course of months than a $160 auto-adjusting conserver will cost you when you consider the savings versus continuous flow. So if a patient cannot saturate on a pneumatic, you probably would then try an electronic. If they cannot saturate on an electronic, I would suggest that you try them on an auto-adjusting electronic, and that is your best chance or your best defense against a continuous flow regulator. You probably have a population of patients, most providers do, that quote-unquote don't tolerate conserving devices. And what does that mean? It probably means that they either couldn't trigger the device or they weren't titrated properly on the device. Certainly it's possible that there are some patients out there that absolutely require continuous flow, but I would submit that auto-adjusting conservers are a great way to try to get those very high operational cost, frequent delivery patients off of continuous flow regulators. And the final way I would use these auto-adjusting conservers are as door openers. Telling clinicians about new technologies, telling them there's something they didn't know before, to make them aware of what technologies they have access to is a win. It's a good story to tell, and it hopefully earns you credibility and brands your company well, hopefully earns you more referrals. And the theme there, I always say, to be a clinical knowledge resource, not an order filler. If a pulmonologist calls up, if their office calls up and says, hey, I've got an oxygen patient for you, they need 2 liters per minute continuous flow, there are providers out there that fill that order, and there are providers out there that take it as an opportunity to educate and become a knowledge resource. We are the experts in the supply chain when it comes to durable medical equipment. Clinicians are not. I can tell you in 3 years of physical therapy school, I got 1 day on wheelchairs. I can tell you in all the years of medical school, they get 0 days on wheelchairs. Yet we're expected, and doctors are expected, to write out prescriptions for DME products. Where are they going to learn about these products? They're going to learn about them from manufacturers and from providers of durable medical equipment. So let's take that opportunity and be that knowledge resource. So, for referral physicians, if you can't get in to see them, if they have difficult to please or difficult patients, if they like new technologies, take an auto-adjusting conserver in, show them something they haven't seen before that solves a real-world problem, ask for a difficult patient and show them what you can do. Treat that patient, you become the clinical resource. Another great message to give is to show the entire suite of conserving device technologies that are out there. Reservoirs, pneumatics, electronics, auto-adjustings. Explain when to use which one. How do you match a product's strength to an individual patient population's needs? That's how you brand your company as oxygen experts. And that's how you grow revenue. So I'm going to wrap up there. I have my email address available for anyone that has any additional questions or comments. I appreciate any and all feedback on the presentation. I hope you've enjoyed it. I